Hi, good night, everyone. My name is Nadia Kanai, and I'll be presenting on hepatobiliary and pancreatic pathology. We have our outline of topics for tonight. We have them divided by organ systems. So in the gallbladder, we'll go through cholelithiasis, acute and chronic cholecystitis, ascending cholangitis, and gallbladder cancer. In liver, we'll touch on hepatocellular adenoma and premalignant lesions, go through hepatocellular carcinoma and other malignant lesions of the liver, metastasis and cholangiocarcinoma, and in pancreas, we'll do acute and chronic pancreatitis, pancreatic neoplasms, and end with pancreatic cancer. So we'll start with the gallbladder. Cholelithiasis affects 10 to 20% of the population, and the majority of these patients are asymptomatic with a conversion rate of up to 4% per year. The symptoms we know as biliary colic after a fatty meal with pain localized to the right upper quadrant and epigastrium with radiation. There are two main types of gallstones we know. The cholesterol stones are more than 50% crystalline cholesterol monohydrate, and pigment stones are made up of bilirubin calcium salts. In cholesterol stones, cholesterol is rendered water-soluble by the aggregation with bile salts and lecithins. Supersaturation occurs and cholesterol crystallizes out of the solution, enhanced by stasis, which then promotes nucleation and mucus hypersecretion and traps crystals, enhancing their aggregation into gallstones. In pigment stones, they are mixtures of insoluble calcium salts of unconjugated bilirubin with inorganic calcium salts. Disorders that cause elevated levels of unconjugated bilirubin in bile increase the risk of formation of these stones or in cases of infection. Cholesterol stones are more than 50 to 100% pure cholesterol, can be pale yellow, round to ovoid, with a hard granular external surface, can have multiple stones ranging up to several centimeters with a rounded surface and are mostly radiolucent, whereas pigment stones can be black or brown, rarely large in size, and a greater number is present, which can be friable with spiculated edges. Most of them are radiopaque, and the brown stones in infection are radiolucent most likely. Acute cholecystitis is the acute inflammation of the gallbladder, which is precipitated by the obstruction of the gallbladder neck or cystic duct by choleliths, ischemia, or substances. It's an abrupt, destructive process of the gallbladder, and more than half of cases are complicated by bacterial infections. Acalculous cholecystitis has a greater complication risk, and these patients are more likely to develop a perforation from gangrenous cholecystitis. The pathophysiology of calculous cholecystitis, there is chemical irritation and inflammation of the gallbladder wall due to the obstruction of bile outflow from the blockage of the neck or the cystic duct. Phospholipases derived from the mucosa hydrolyze biliary lecithin to lysolecithin, which injures the mucosa. The normal protective glycoprotein mucus layer is then disrupted, which exposes the mucosal epithelium to the detergent action of the bile salts. Prostaglandins are then released within the wall of the distended gallbladder, which enhances mucosal and mural inflammation, causing further distension, further increased intraluminal pressure, and this then compromises the blood flow to the mucosa, which ends in the gallbladder ischemia and necrosis. On gross examination, the gallbladder can be distended and edematous with a bright red serosa from subserosal hemorrhage. It can be seen to be covered in fibrinous or fibrinopurulent exudates with thickened, edematous hyperemic walls, mucosal ulcerations, and turbid bile in the lumen, which can contain fibrin, pus, choleliths, and a fluid mixture of cholesterol and calcium carbonate. In specific cases of gallbladder empyema, this turbid exudate can be fully purulent. In a gangrenous cholecystitis, the wall is thickened, necrotic, and can be green-black with multiple small to large perforations, as well as neutrophilic inflammation. And in emphysematous cholecystitis, this involves the invasion of gas-forming organisms such as Clostridia and coliforms. So just to run through our normal gallbladder histology, so you have your mucosa arranged into numerous folds. The underlying muscularis layer is thin, and below this is the adventitia or subserosa. So this is the layer that contains the blood vessels, the nerves, and the adipose tissue. And the cystic duct, you could see the lamina propria here within the folds. So now we could talk about the histology of acute cholecystitis, where there are inflammatory cells if there's a secondary bacterial infection. Mucosal erosion with edema is seen, as well as possibility of seeing myofibroblast, lymphocytes, plasma cells, eosinophils, and pigment-laden macrophages. There can be fibrin deposition with thrombi seen in small veins, as well as fibrinoid necrosis. So in the first picture, you could see here the hemorrhagic lamina propria with erosion of the mucosa as well, and this area of inflammatory cell infiltrate. In the second picture, again, extensive hemorrhagic deposits in the lamina propria, these red areas. And the last is a higher power image showing distortion of the architecture and the loss of the layers, which we know is still necrosis, as well as pale areas distributed throughout, which is fibrosis, together forming the fibrinoid necrosis, with some inflammatory cells deposited throughout. Chronic cholecystitis is the possible sequelae of recurrent attacks of the acute cholecystitis, or can happen without any antecedent history of acute attacks, aside from the supersaturation of bile. It's a pathological diagnosis based on the examination of a resected gallbladder. Microorganisms can be cultured from bile in about 1/3% of cases, and it's typically related to cholelithiasis, either through direct mucosal irritation or via intermittent mechanical obstruction of the cystic duct with associated alteration of the chemistry of the bile. It's generally diffuse and not specific to any specific region of the gallbladder. On general examination, the gallbladder can be contracted or shrunken. The serosa may be either smooth or subserosal fibrosis can be seen. Dense fibrous adhesions can be seen to adjacent organs. The wall can be thickened, opaque, and white-gray with a granular, ulcerated, or polypoid mucosa. There's an inflammatory infiltrate seen in the lamina propria in chronic cholecystitis, consisting of T lymphocytes, plasma cells, histiocytes, and eosinophils, and occasionally the lymphoid follicles can be seen. There's also hypertrophy of the muscularis, and in mild cases, versus severe cases, a subepithelial and subserosal fibrosis is seen in these cases, with a reactive proliferation of the mucosa, and then the mucosal folds fuse, which gives rise to these buried crypts of epithelium within the gallbladder wall. These are prominent Rokitansky-Aschoff sinuses, which are outpouchings of the epithelium through the wall of the gallbladder itself. Also may occur as adenomyomatous hyperplasia or metaplastic changes. Right, so on the left, we could see the mucosa of the gallbladder with many inflammatory cells distributed within the lamina propria. Then next, we could see that mucosal folds basically usually stop at the lamina propria, but in this area, the mucosal folds extend into the muscularis propria, forming pseudodiverticulae, and this is what we call the Rokitansky-Aschoff sinus, which is filled with bile. Seen here is the same extension, so basically at the lamina propria, but extending into the muscularis propria layer. We could see the Rokitansky-Aschoff sinuses, and as well as a thickened mucosal layer from chronic inflammation. The last picture, we could see a eroded, flattened mucosa with missing folds demonstrating mucosal atrophy in chronic cholecystitis. Ascending cholangitis is a secondary bacterial infection of the biliary tree that aggravates the inflammatory injury from subtotal or intermittent obstruction. Its most severe form is suppurative cholangitis, and this is where purulent bile fills and distends the bile ducts. Symptoms can be in the form of Charcot's triad or Raynaud's pentad, and common infectious causes are E. coli, Klebsiella, or Enterococci. The histological hallmark is an influx of periductular neutrophils directly into the bile duct epithelium and lumen. So here on the left, we could see the bile duct with a mixture of inflammatory cells, inclusive of neutrophils, both inside the lumen and surrounding the duct as well. And the same could be seen on the right. Moving on to gallbladder cancer. This is the carcinoma of the gallbladder, which arises from the epithelium, the most common malignancy of the extrahepatic biliary tract. And most are adenocarcinomas, with 5% being squamous cell carcinomas. It has a mean 5-year survival of less than 10%, and the most important risk factor is cholelithiasis as a result of chronic inflammation. It primarily affects the fundus at 60%, then the body and neck, whereas advanced tumors involve the liver and the extrahepatic biliary tree. In advanced cancers, you could find an elevated ALP as well as CEA, but with only a 50% sensitivity. The pathophysiology of gallbladder cancer involves, as discussed, long-standing cholelithiasis, causing inflammation, resulting in metaplasia, then epithelial dysplasia and carcinoma in situ develops. It takes approximately 15 years to advance to gallbladder carcinoma. Common genetic alterations found were in more than 50% of cases TP53, as well as CDKN2A in about 20%, and some other alterations as well. Also found has been oncoprotein ERBB2 amplification in about 16% of cases, and microsatellite instability in 10%. In 25% of cases, mutations of chromatin remodeling genes have been found. Most of these cancers are adenocarcinomas, as discussed, some papillary in architecture and well to moderately differentiated, whereas some are infiltrative and poorly differentiated to undifferentiated. There are pre-neoplastic lesions that occur adjacent to invasive cancer as well, seen as flat dysplasia with varying grades of cellular atypia, including the carcinoma in situ. 2 patterns of growth have been found: infiltrating, which is more common, as well as exophytic, which is where it grows into the lumen as an irregular mass, which invades the underlying wall. Multiple histological types have been classified, the most common being biliary type adenocarcinoma at 75%. This is similar to pancreatic ductal adenocarcinoma. It's composed of tubules embedded in a desmoplastic stroma. Moderately differentiated is more common, but has a wide histological spectrum from deceptively bland to poorly differentiated. There's also intestinal type adenocarcinoma, which is very similar to colonic adenocarcinoma. Tubules are lined by columnar cells with elongated hyperchromatic nuclei. Mucinous carcinomas are comprised of more than 50% extracellular mucin. Clear cell carcinomas are sheets of clear cells in an alveolar arrangement separated by blood vessels, and this one is similar in appearance to clear cell renal carcinoma. Other histological subtypes are signet ring carcinoma, hepatoid carcinoma, and sarcomatoid carcinoma. Running through the normal gallbladder wall histology, we could see round mucus glands lined by mucinous cells with cuboidal nuclei. And in malignancy, you could still see some glands, well-formed glands, and in adenocarcinoma, the cancer comes from the glands with atypical cells making up the glands themselves. So these malignant features are seen, which are prominent nucleoli, pleomorphism, which is variation in the cell size and the shape, as well as fibrosis. So this could be seen on your right as well, with dense fibrous tissue forming around the tumor termed desmoplasia. Positive stains for gallbladder cancer are CK7, which is strong and diffuse staining. The majority is P53 as well. CEA and CA19-9 in 70 to 90% of cases. IMP3, MASPIN, S100P, and MUC1. And just a quick AGCC guideline on the 8th edition of the gallbladder cancer staging, which you could read. So we can move on to liver now. Hepatocellular adenomas have been detected incidentally or from abdominal pain from their rapid growth, which causes pressure on the liver capsule, or when the lesion outgrows its blood supply and develops hemorrhagic necrosis. Also have been found in cases of rupturing, leading to intra-abdominal bleeding. The highest risk of malignant transformation is the beta-catenin activated adenoma, and this is from mutations mutations in the beta-catenin gene leading to atypia. It's associated with oral contraceptive use and anabolic steroid use. Some other benign tumors are the HNF1 alpha inactivated adenomas and the inflammatory adenomas. So just a picture of the subtypes of the hepatocellular adenoma as discussed before, and the staging. So hepatocellular carcinoma is the most common primary liver malignancy worldwide in 80% of cases. The highest incidence is in Asia and is the most common cause of cancer mortality worldwide. It's associated with hepatitis B and hepatitis C virus infection, as well as in countries exposed to aflatoxin as the risk increases due to synergizing. It's most commonly associated with chronic liver disease, and the most important underlying factors are, as discussed, the viral infections, as well as alcohol and aflatoxins. And there have been specific subtypes with molecular and cytogenic abnormalities, as discussed. It can arise from malignant precursor lesions. We spoke about the hepatocellular adenoma, but also cellular dysplasias and chronic liver disease and dysplastic nodules. So low grade is a possible transformation to a higher grade lesion and a higher risk for HCC, whereas high grade is the most important primary pathway for the emergence of hepatocellular carcinoma. Dysplastic nodules have a different appearance from the surrounding cirrhotic nodules, whether it be size, vascular supply, color, or texture. And low-grade dysplastic nodules have no cytologic or architectural atypia, but they are probably neoplastic with portal tracts still present within them. High-grade dysplastic nodules have these cytological or architectural features like occasional pseudoglands and trabecular thickening, but it's still insufficient for the diagnosis of hepatocellular carcinoma. The cellular dysplasias, you could see the large cell change, which is scattered larger than normal hepatocytes near the portal tracts receptor. So there's large pleomorphic nuclei with a high nuclear cytoplasmic ratio in the second image, as well as pleomorphism and mild nuclear hypochromasia. And well, on the lower right are some normal hepatocytes. You could see the difference. The pathophysiology of hepatocellular carcinoma involves a stepwise process accompanied by accumulation of molecular alterations. So it starts with the low-grade dysplastic nodule from prior, advances to high-grade dysplastic nodule, early hepatocellular, and then progressed hepatocellular carcinoma. The alterations found have been telomere shortening, TERT activation, and cell cycle checkpoint inhibitor activation. So the third promoter mutation is actually the most important event noted in the hepatocellular carcinoma progression. There's also acquired driver mutations, such as the gain of function mutations in beta-catenin and loss of function mutations in p53. On a gross examination, hepatocellular carcinomas may appear as a unifocal large mass, multifocal, widely distributed nodules of variable size, or a diffusely infiltrative cancer. They appear pale compared to the surrounding liver, or in different differentiation states may appear variegated. The natural course of hepatocellular carcinoma is progressive liver enlargement, or progressive enlargement of the primary mass until it disturbs either the hepatic function or metastasizes. Intrahepatic mets are more likely when these tumors are more than 3 centimeters, and they appear as small satellite tumor nodules around the primary mass, whereas extrahepatic mets spread by the vascular route, hematogenous mets to the lung, and invasion of even the portal vein or the IVC. So just the normal liver histology again. You can see the lobule with a central vein and surrounding portal tracts. On the right, the hepatocytes themselves with the abundant eosinophilic cytoplasm, round central nuclei with prominent nucleoli seen. And canaliculi, not usually seen, but this is a case of cholestasis, so it's dilated. So in hepatocellular carcinoma, on the left, you could see malignant hepatocytes growing in these distorted architectural ways with these large spaces resembling glands and thickened trabecula, with a high nuclear cytoplasmic ratio, multinucleated cells, as well as prominent nucleoli. There are two major architectural patterns seen: trabecula on the left, growing in files, and pseudoacinar, which is basically gland forming. The staging of hepatocellular carcinoma is done by the Barcelona Clinic Liver Cancer Staging System, which groups hepatocellular carcinoma into prognostic stages and then based them on treatment and survival. Other liver tumors, primary hepatic malignant tumors, hepatoblastoma, angiosarcoma of the liver, mucinous cystic neoplasms, and hepatic lymphomas as well. And as we know, the liver is the most common site of metastatic cancers from primary tumors elsewhere, and involvement of the liver by metastatic malignancy is more common than any primary hepatic neoplasia. Cholangiocarcinomas are the second most common primary malignant tumor of the liver after hepatocellular carcinomas. They arise from both intra and extrahepatic bile ducts and account for 7.6% of cancer deaths worldwide. The pathophysiology of cholangiocarcinoma involves chronic inflammation and cholestasis, which promotes the occurrence of somatic mutations or epigenetic alterations in the cells, the cholangiocytes. Risk factors can be chronic inflammatory diseases of the bile ducts, liver fluke infestation, fibropolycystic liver disease, or hepatolithiasis. Sites can be extra or intrahepatic, as discussed, mostly perihilar with 50 to 60%, and these are the Klatskin tumors located at the junction of the right and left hepatic ducts. 20 to 30% are distal tumors, and with the intrahepatic, there can be small duct type versus large duct type. Premalignant lesions found for cholangiocarcinoma. The highest grade lesion found was the biliary intraepithelial neoplasia 3. Rarer premalignant lesions are mucinous cystic neoplasms and intraductal biliary neoplasia. On gross examination, these appear as firm gray nodules within the bile duct wall. Some can be diffusely infiltrative versus papillary or even polypoid. They are mostly mucin-producing adenocarcinomas with glandular or tubular structures lined by malignant epithelial cells, and in these tumors, they have a marked desmoplasic reaction. Lymphovascular and perineal invasion is also common. So on the left, there's a densely sclerotic stroma with fibrosis, as well as scattered invasive malignant glands. And on the right is a nerve with malignant glands surrounding and trapping it, demonstrating perineal invasion. So the pancreas is a retroperitoneal, transversely oriented organ extended from the duodenum to the hilum of the spleen, separated into parts, the head, the body, and the tail. The location of the pancreas allows many diseases to progress undiagnosed, and as such, cancers present at later stages. The acinar cells synthesize digestive enzymes, which are inactive proenzymes stored in the zymogen granules, and then these fuse with the apical plasma membrane to then release their contents into the lumen, the central acinar lumen. The epithelial cells lining the ducts are cuboidal cells, which secrete bicarbonate-rich fluid, and columnar cells, which produce mucin. In acute pancreatitis, this is a reversible inflammatory disorder of the exocrine pancreas that varies in severity from either focal edema and fat necrosis to widespread hemorrhagic necrosis. The most common cause in 20 to 70% has been found to be gallstones. The impaction of gallstones within the CVD impedes the flow of the pancreatic enzymes through the ampulla vata. In 30%, it has been found to be excessive alcohol intake. Alcohol transiently increases pancreatic exocrine secretion and the contraction of the sphincter of Oddi. It also has direct toxic effects on the acinar cells, which leads to the membrane damage, secretion of protein-rich pancreatic fluid, which then deposits thick protein plugs and obstructs the small pancreatic ducts. Other causes are hypertriglyceridemia, and as well as medications, infections, metabolic disorders. The pathophysiology is caused by the autodigestion of the pancreas by inappropriately activated pancreatic enzymes. It can be triggered by factors that disrupt the normal intracellular calcium signaling in pancreatic cells. And pro-inflammatory cytokines mediate a powerful immune response, and this is what leads to serious multi-organ dysfunction and a higher susceptibility to infections. So 3 pathways have been found. One of them is pancreatic duct obstruction. It occurs when the normal ductal flow is impeded by the gallstone impaction or biliary sludge, or by an extrinsic compression of the ductal system by a mass. The pressure, the intraductal pressure, then increases. There's accumulation of enzyme-rich interstitial fluid and localized fat necrosis from lipase. Pro-inflammatory cytokines are released by leukocytes, acinar myofibroblasts, and injured tissues, which then promotes local inflammation, leading to interstitial edema, then vascular insufficiency and ischemic injury of the acinar cells from this compromised local blood flow. The second has been found to be primary acinar cell injury, which leads to the release of digestive enzymes and the autodigestion of the pancreatic tissues. Oxidative stress generates free radicals in the acinar cells, which leads to membrane lipid oxidation and activation of transcription factors, which then induce chemokine expression and attract mononuclear cells. The last is the effective intracellular transport of proenzymes within the acinar cells, where the proenzymes are inappropriately delivered to the intracellular compartment, which contains lysosomal hydrolysis, and this causes their premature activation and release. So to summarize that, microvascular leakage causing edema, necrosis of the fat by the lipases causing an acute inflammatory reaction, the proteolytic destruction of the pancreatic parenchyma, and then the destruction of the blood vessels, leading to interstitial hemorrhage. And a more detailed pathophysiology of the acute pancreatitis. Histology, we could see in acute edematous pancreatitis, there's interstitial fibrous tissue, which becomes edematous, as well as the adipose tissue on the pancreatic parenchyma. And then there's the infiltration of acute inflammatory cells. In necrotizing pancreatitis, there can be marked hemorrhage with coagulative necrosis and fat necrosis of the peripancreatic tissues, as well as the presence of intravascular thrombi. Hemorrhagic pancreatitis involves extensive parenchymal necrosis with diffuse hemorrhage seen within the substance of the gland. Initially, there would be a conglomeration of neutrophils, followed by macrophages and then lymphocytes. Calcification is seen in pancreatitis and it occurs early on and is very extensive. Fat necrosis is characterized by the lipid-laden macrophages and foreign body giant cells, which then progresses to fat saponification, and this leads to more calcium deposition. And the normal pancreas and medium power, you could see the interlobular ducts and the islet. So then you can see the difference here on the left, the architecture and the glands, some of them are preserved, but there's a large amount of inflammatory cells distributed throughout the parenchyma. On the right, the neutrophils and the lymphocytes are seen, with some plasma cells as well. And in hemorrhagic pancreatitis, there's this loss of ability to see the glands, which is necrosis, admixed with the red areas of hemorrhage and pale areas of fibrosis. Chronic pancreatitis In this case, there is pancreatic fibroinflammatory syndrome, which is histologically characterized by parenchymal fibrosis, atrophy, and duct changes. Clinically, the patient would have pain and symptoms of pancreatic insufficiency may develop. It's a chronic inflammatory disorder leading to irreversible destruction of the exocrine pancreas, as well as loss of the islets of Langerhans. There are four main etiologies. One is alcoholic pancreatitis, obstructive pancreatitis, hereditary or paraduodenal pancreatitis. The pathophysiology involves ductal obstruction by concretions, which form the ductal plugs. There can be direct effect by the toxic metabolites of the alcohol. Oxidative stress, which generates the free radicals in the acinar cells, leading to membrane damage and expression of the chemokines, which then recruit inflammatory cells, which also promotes fusion of the lysosomes and zymogen granules with progressive acinar cell necrosis, inflammation, and fibrosis. There's the inappropriate activation of pancreatic enzymes, and pro-fibrogenic cytokines are secreted by these infiltrating immune cells, which activates and proliferates the periacinar myofibroblasts, which then deposit the collagen, giving rise to the successive fibrosis. Gross examination is a whitish parenchyma. Extensive fibrosis, dilated ducts and calculi. It still retains the lobulated appearance, but in advanced stages, there's reduction in the volume of the gland. There are calcifications, multiple parenchymal and intraductal calcifications, pseudocysts, more seen in alcoholic pancreatitis, and retention cysts in obstructive pancreatitis. Specific to paraduodenal pancreatitis, there can be cystic change near the minor ampulla, and the trabeculated fibrosis is centered around the duodenal wall itself. There is a trial of cardinal features: fibrosis, duct changes, and loss of acinar tissue. In the intralobular area, the fibrosis is initially perilobular, then it extends to the lobular units, which then replaces the acinar parenchyma with the fibrosis or the fatty tissue, and then extends outwards to the pancreatic islets. In ductal changes, there's distortion of the profiles and ectasia, presence of these protein plugs, so that's the intraluminal concretions, leading to squamous metaplasia and intraductal calcifications. There have been found foci of low and high-grade pancreatic intraepithelial neoplasia, as well as periductal chronic inflammation, fat necrosis, and pancreatic pseudocysts, which are liquefied areas of necrotic pancreatic tissue walled off by fibrous tissue, which is the granulation tissue in the fibroblasts, and this forms the cystic space, which lacks the epithelial lining, and the cyst contents are rich in pancreatic enzymes. So we could see the cardinal triad here. The pale areas would be fibrosis areas. There's these dilated glands with protein plugs and aggregates of pancreatic ducts and some inflammatory cells seen. Cystic neoplasms are diverse tumors which could range from harmless benign cysts to lesions that may be precursors to malignancy. This accounts for less than 5% of all pancreatic neoplasms. A benign lesion is a serous cystadenoma or serous cystic neoplasm, accounting for 25%. These occur in the tail, multicystic, small, and lined by glycogen-rich cuboidal cells surrounding small cysts containing clear straw-colored fluid. The genetic abnormality seen is the inactivation of the VHL tumor suppressor gene. Two premalignant lesions are the mucinous cystic neoplasms, which are slow-growing masses in the tail, contain larger cystic spaces filled with thick mucin, and cysts lined by columnar mucinous epithelium with densely cellular stroma. In these patients, the genetic abnormality has been found to be with the KRAS oncogene and TP53 and RNF43 tumor suppressor gene mutations. The other premalignant was the intraductal papillary mucinous neoplasms. These arise in the main pancreatic ducts or the major branches in the pancreatic head. they lack the cellular stroma seen in the mucinous cystic neoplasms, and the epithelium harbors various grades of dysplasia, with a subset associated with the invasive adenocarcinoma. Mutations in GNAS and the KRAS oncogenes have been found, as well as TP53, SMAD4, and RNF43 tumor suppressor genes. Pancreatic cancer is the fourth leading cause of cancer deaths in the US and one of the highest mortality rates of any cancer, with a less than 5% 5-year survival rate. It's an infiltrating ductal adenocarcinoma of the pancreas, which produces an intense desmoplastic response. The strongest environmental influence has been found to be cigarette smoking, but other risk factors are alcohol, obesity, saturated fat consumption, chronic pancreatitis, and diabetes mellitus. These tumors remain silent until they invade into adjacent structures. Signs and symptoms may include abdominal pain, obstructive jaundice, weight loss, malaise, Trousseau sign, or diabetes mellitus, new onset. Less than 20% of these cases are resectable at diagnosis, and some less common variants of the pancreatic cancer are adenosquamous carcinomas, colloid carcinomas, hepatoid carcinomas, medullary carcinomas, or signet ring carcinomas. So these Panin is a premalignant lesion, and there's a Panin invasive carcinoma sequence as well. It's supported by certain observations, and this one can be found as the highest risk, which is grade 3, and it still doesn't breach the basement membrane. So it starts as non-neoplastic epithelium, progresses to Panin, and then to invasive carcinoma in the small ducts. Epithelial cells of these show critical telomere shortening, which then progresses to the accumulation of these progressive chromosomal abnormalities after. So this is the invasive carcinoma sequence. In pancreatic carcinoma, multiple genes are either somatically mutated or epigenetically silenced. So the Panin invasive carcinoma sequence involve 4 main somatic mutations: the oncogene KRAS and tumor suppressor and DNA repair genes, as seen in the diagram. So it's SMAD4, TP53, as well as the P16, and BRCA2 has been found to be implicated. So KRAS is the most frequently altered oncogene. It has the presence of activating point mutations in 90 to 95% of cases, and it impairs the intrinsic GTPase activity of the KRAS protein so that it's always active. And this then activates the intracellular downstream signaling pathways that promote carcinogenesis. The most frequently inactivated tumor suppressor gene is the CDKN2A gene. It's turned off in 95% of cases. It has a critical role in cell cycle control. It encodes 2 tumor suppressor proteins. The SMAD4 tumor suppressor gene is often about 55% of cases, and this one codes for a protein that helps in signal transduction downstream of the TGF-beta receptor family. There's also in about 70 to 75% of pancreatic cancers, the inactivation of the tumor suppressor gene TP53. The gene product acts to enforce cell cycle checkpoints and induces cell apoptosis or senescence. And as well as BRCA2 tumor suppressor genes are mutated late in a subset, and these occur in higher grade lesions as seen in the previous sequence. The morphology, 60 to 70% arise in the head of the pancreas, which is then followed by the body and the tail, and some diffusely involve the entire pancreas. They are poorly defined, hard, gray-white stellate masses, and highly invasive to peripancreatic tissues, and also elicits an intense desmoplastic reaction, which shows up as the dense fibrosis we looked at before. In the head of the pancreas, which is about 50% of cases, it obstructs the distal CBD, which then causes biliary tree distension and leads to jaundice. And in these cases, 85% of cases have extension beyond the pancreas at the initial diagnosis. Tumors in the body and tail of the pancreas remain asymptomatic as there is no impingement of the biliary tract, but they are also widely disseminated on diagnosis, with 25% having peripheral venous thrombi. Pancreatic cancer extends through the retroperitoneal space and also has nerve and blood vessel involvement, with direct invasion into the surrounding organs, so the spleen, adrenals, transverse colon, and stomach. And there's also lymphatic spread to the peripancreatic, gastric, mesenteric, omental, and portohepatic nodes, followed by distant mets to the liver and the lungs. On histology, we could have the moderately to poorly differentiated adenocarcinoma with a deeply infiltrative growth pattern and frequent mitoses, the desmoplastic reaction, a dense stromal fibrosis, perineal invasion, lymphatic and large vessel invasion, poorly formed malignant glands lined by these pleomorphic cuboidal to columnar epithelial cells. So you could see the poorly formed glands within this densely fibrotic stroma with a lot of inflammatory cells and frequent mitoses seen. So in pancreatic cancer on the left, we could see significant pleomorphism, which is like discuss the varying cell shapes and cell sizes in the same gland. Moderately differentiated still maintain some of this glandular structure, but with significant desmoplasia. Whereas poorly differentiated, the cells are no longer recognizable with these incompletely formed glands. And on the right, there is tumor surrounding the nerve, which is indicative of this perineal invasion. Positive stains are Maspin, placental S100, IMP3, which is more than 90% of cases, and in most cases, P53 is a positive stain. And we have the staging according to the AGCC guidelines with a comparison of the 7th and 8th editions, with prognostic factors depending on the stage and the tumor size. So for some favorable prognostic factors are if the tumor is resectable or less than 4.5 centimeters, and unfavorable are if there is perineural or vascular invasion present, if there's a high histologic grade, or if there's a squamous component. And that's my references, and that's all for my presentation. Thank you.